We are. Perfect. Well, thanks everyone for coming this evening to our live discussion event sponsored by the National Network of Healthcare Hygienists. My name is Colette Murray and I'm the member coordinator here at the network. Before I introduce our guest for the evening, I wanted to tell you a little bit about the National Network of Healthcare Hygienists and our programs if you're not familiar. We are a nonprofit organization that offers online education in the form of certificate programs for registered dental hygienists. Our programs further our goal of integrating dental hygienists into healthcare settings by developing their oral systemic knowledge, which improves health outcomes for patients in our communities. We currently offer 6 training and certificate programs seen here on the website. If you'd like to head over here at some point to take a little bit closer look at what we have to offer, we've got our most robust program, our Oral Systemic Educator Certificate Program. This would be our flagship program, almost 35 hours of content here. You can view the outline and enroll on this tab here. We also have our Oncology Certificate Program, which is 18 hours. We have our Leadership and Quality Improvement Program. That one is a micro-credential. It's 7 hours of CE. All of these also come with certificate of completion and a digital badge that you can display on your digital platforms. Here you can subscribe to a weekly newsletter just to stay abreast of everything that's going on. We have our Cotton Method Certificate Program. This is also a micro-credential, 3.5 hours. Great program there, as well as our Oral Facial Recovery Certificate Program, which is a level 1 program. This one too is 15 hours of content. In addition to these, we do have a interprofessional education competency training for hygienists. This is a new addition recently, and coming down the pipe this fall is our Airway and Sleep Medicine Certificate Program. We do have a wait list for that. So if you wanted to hop on that, if you have interest in the airway and sleep medicine content, then you would get special pricing as the early bird launch happens, I believe, in September, possibly October, I think September of this year. So just next month. And now, our speaker. Lisa Stevwing is a registered dental hygienist with more than 25 years of experience who made an inspiring transition from private practice into hospital infection prevention. After experiencing burnout, Lisa stepped into a facility coordinator role at West Penn Hospital, where she discovered a new career path that built naturally on her expertise in sterilization and infection control. Today, Lisa is board certified in infection control and works within a 10-hospital network supporting a 356-bed hospital through disease prevention, staff education, and process improvement. She also continues to champion the important connection between oral and systemic health, and particularly for oncology patients. So let's welcome Lisa. We are excited. We're excited to hear how you turned your burnout into a new calling.
Well, thank you very much for having me. And it was something that it was a little bit unexpected to find this career path. I thought I would transition into the facility coordinator role and see where that took me, maybe outside of the hospital, back into dental somewhere. And I haven't presented infection prevention. And that was something that I think, as every hygienist had done their entire career, was trying to prevent gingival infections and improve oral health and patient outcomes. So I just sort of transitioned how we did it, where we did it, and in the hospital setting as a portion of what I do every day.
Very cool. Well, we certainly have an expertise in infection prevention control, so it's something within our wheelhouse, but we always just think of that as part of what we do, not necessarily just what we do. It's part of the big picture, but for you, it is the big picture.
That is true.
So looking back, question for you, what do you think were the signs that told you that it was a time for a change for you? What were you experiencing in your career after several years?
Well, this all started around 2020, 2021 with, I think, everybody with COVID, but physical problems, shoulder, back, hip, I think that initiated everything. As many of us who'd been practicing a long time, I'd already been through physical therapy for my wrist and going to the chiropractor, trying to really help with posture and improve flexibility with my shoulder. Just every day, the repetitive motion. I would have exercises to do in between patients if you could, just trying to stretch things out. And the lack of PPE and staff that we faced in the hygiene world, not being able to share hygienists that were helping us, the Wednesday girl, the Thursday girl, the Saturdays, we would have 5 hygienists going with the pediatric population coming through. That all stopped. Their main office did not want to share staff. So I was the only hygienist that was full-time. And we had somebody that worked for us 2 days a week, and she had younger children. And I'm thankful for her, because with her help, it helped sustain us through that transition where we lost a good portion of our staff. So not only the physical changes, the staffing changes, it was starting to not be fun anymore. And not fun that you go to work and think it's a party, but the fun, that the enjoyment, the fulfillment that you did get out of having the patient interactions, the cleanings, the doing everything was more of a task that was hard to want to go to work and find the pleasure in it. So when the opportunity was faced, and it's actually 5 years ago this week, it happened. A friend of mine said, there's an opportunity that presented itself. Is it something you would be interested in? It's not that you couldn't do the job. It's you're overqualified for it, is what she said.
Was she a dental person, Lisa?
No,
or was
she
a
worked,
hospital
she
person?
worked at the hospital. I had known her for years, and her husband, and she was always trying to get me to go and work with her. She was the director of patient access there. But with the patient access, we all say terms that are different hospital-wise as opposed to our little micro dental world. She was the director of everybody that would come in and do front desk. So they would do some scheduling, they would do payments, they would enter the insurance, they would process, send the claims off for processing, things like that. That was that first front desk line. They're 24/7, whether you're in the ED coming in or you're in the doctor's office. So she would always be like, you can always come and work for me. But that was still another schedule that was going to maybe not be 9 to 5. Maybe then the holidays and the weekends, you're starting off on a different schedule, new person in. So it just wasn't the right fit. So she said, that facilities director needs a coordinator. His coordinator was with him for years, but she moved up into the administration office, which was a wonderful opportunity for her. I think you're overqualified for this. You've done ordering, you've done timekeeping, you've done things. It's a staff of probably about 30 people in the facilities department. Are you interested? And here, coincidentally, before our office moved, our office was in the professional building of the hospital. So I had interactions with the facility department. Small world, correct?
Yeah.
So when I go in for the interview, the person that we remodeled one room was my contact point. And he goes, I can't believe you're here. You ran a lot of the back end of the office. Why are you thinking of leaving? And we had just moved in February, and this was August. And I had said, you know what? I'm tired. I need something new. And so it presented itself as an opportunity, and with the ability to get benefits, but more so the retirement, the short-term disability, the long-term disability, the things a big company can offer you that unfortunately a small business doesn't have those incentives for the employees.
We are missing that in our profession for sure.
We really are. So after I was hired and worked with him, he goes, we don't know why you took this job. And I go, well, it's because you two are the kindest people that I've ever met. just to go ahead and do it.
You
But
work.
it just worked out that the financial end then became a benefit. Sure, I was working more hours in the week because I was about 4 days a week, 32, 35 hours. This was now a 40-hour job, but that little bit of difference in pay and then having them contribute to retirement, I actually came out financially improved from the position that I was doing with dental hygiene. So
And less of the physical work, I would think. Less of that
much,
real, yeah.
much less. This was basically computer work. Sure, we would go rounding and things in the hospital, but it was not a time schedule to keep, to
Right.
worry about. Sure, you have your meetings, things of that nature, but not, I have someone coming in 15 minutes. I need to get an exam. I need to schedule. I need to turn over. I need to start the autoclave. I need to make sure I'm prepped for the next person. Is the sensor ready for me to go for x-rays? Everything
And
there. And
managing
then,
others' emotions as well, right? We know a patient is different than a coworker. Well, sometimes.
Absolutely. Absolutely. Managing the emotions of everybody coming in who's running late, who's just nervous for the dental office. And not to mention sometimes the coworker as well, that, oh, every time I come in here, the ultrasonic is full or the autoclave needs started. Or we know how everybody's busy in the dental office and we're all trying to exist and make things run smoothly. And of course, then the patients that need added in and that extra x-ray, that do you have 3 seconds to go in and take an x-ray, which we know it's not 3 seconds, but that was maybe the opportunity that you were going to use the restroom and grab a drink and maybe,
Take that rock out of your shoe.
exactly. I think we lived on the peanut butter filled pretzels for many years because with COVID and the restrictions and the N95s and not being able to take them off during that time, there was really no lunch break because we didn't have the availability of some of the PPE in order to go ahead. And once you took it off, you then had to brown paper bag it and go ahead and put on another. And we just simply, supplies were short.
So you were told about the infection prevention position. Were you automatically thinking, I can do this? Or were you like, ugh?
Well, I was very intrigued because it was a 2-person position. The manager was a nurse and the infection preventionist had a microbiology background. And I thought, okay, because a lot of times you do hear of the infection prevention, the infection control nurse. Didn't realize the possibility was that a lot of organizations and institutions transitioned away from RNs. Not that they're not able to be it and apply. Absolutely. We have several RNs. It's just that wasn't the best path for them to take. There was so many more options for nursing within the hospital system that infection prevention, unless you had that passion, was not something everybody gravitated to. I'm the bad guy in a lot of situations when I explain why we can no longer do that process. Even though they've been doing it for 40 years, we no longer share patient supplies. That roll of tape cannot stay on your stethoscope and it needs wiped between patients. Simple things, but there are a lot of people that don't like to hear the message. So not just in nursing, trust me, within all levels of hospital employees. So a lot of times it was hard for them to do their coworkers and make, corrective suggestions as opposed to somebody coming in and going, that's not what we do. That's not our hospital policy. So when I looked at what the position was, because, the manager was fortunate enough to be able to retire and the infection preventionist was now the manager, her position was open. So I thought, let me see. And when I read what the qualifications were, I'm like, well, I've done that. I've done that. Definitely have done that. They asked if I knew sterilization. I'm like, what would you like me to walk you through? So there was a lot of the benefits of doing sterilization that even now I'm part of the network. I'm the IP representative for the central processing and have been on a lot of the calls because we speak their language. We understand where they're coming from and know what is needed and the process of doing it. So I applied for the position and I had worked with both of the infection preventionists during rounding for the hospital. And I was fortunate enough to bring a perspective to our group that has led to be an asset for them. So I was
For
happy to
sure.
contribute.
Oh, very cool. Very cool. Okay. I'll just take a little bit of a pause here. If anyone's having any other questions that kind of occur to you while we're chatting here, please go ahead and drop those into the group chat, and then we can address them as we're going along or at the end. So if any of the attendees are thinking of other things they'd like to know from Lisa, go ahead and just throw that in the chat. Moving on, I wanted to ask you, what do you think was the biggest learning curve when you transitioned from the dental office to this hospital setting?
The biggest learning curve, I would think, was the hierarchy of how things happen there and the snail's pace of which things get done. So, once you know who the players are and the conversations that you have and things that you're doing, you think, okay, great. I need to make a change. We need a new product. We need to, order instruments because we had residents coming from another hospital doing extractions on our patients that were too sick to transfer, our bone marrow transplant patients, and they were abscessed. So I'm reading a chart and learning that they're actually bringing the instruments from the other hospital to us, which everybody in the dental world, when I say I put on my hygiene hat, what are you talking about? I took my instruments when I traveled between the offices. For the rest of the world, in the hospital world, you do not do that. They're sterilized instruments. They need to be temperature and humidity controlled. You cannot bring them between facilities, and then you certainly cannot bring dirty instruments back. No private vehicle, nothing like that. So when I brought this up, it took me a year in order to order the dental instruments, to have them available for the residents, to get education. We're just getting the education, not only to nursing of the new process of where they're kept. If I told you that it took me 2 months to order a box of lidocaine, we all here would laugh because we have lidocaine coming out of our ears. It had to be done by pharmacy. It needs to be kept in the Omnicell. They could not find the order number for it. So the incremental progress, I'm like, it's a year to order 3 forceps, an elevator, a mirror, and
wow,
a syringe.
that's mind-boggling.
It was unbelievable. And I'm like, nope, this is the hospital world. This is it. And then I was lucky that none of this needed to go through new product care committee, because if there is something that you want, dental world, we have a rep come in, try my great new project. It's probably been kept in his trunk or in the back seat of his car. We take it, go ahead and use it on a patient and don't think anything of it. That doesn't happen in the hospital world. It's me that says absolutely not. I don't know how that was stored. Is this a sterile product? Was it in temperature and humidity controlled? What was the manufacturing like? How was it kept? Was it made with the best products? Because it could be contaminated from the manufacturer. It's not scanned in anything to go into the patient's chart in the event that it's recalled. So there's that complete disconnect that, no, we just can't get a sample and use it. We actually need to go through product care committee. It needs approved. It needs to then go to purchasing to see if it's something that will go through value-based purchasing. And maybe about 9 months later, we can incorporate that product in there. So
wow,
it's something that learning that process of it, coming from the background, like, why don't we just call Shine? We can get it here in 24 hours.
Yeah.
Patience, I think, then maybe was the next thing that I needed to.
Patience, for sure.
To learn, yes.
Sure. Oh, interesting. Well, why don't you tell us about a regular day in the life of Lisa? You touched on a few things, but.
Yes. So, I think I should get into a little bit of what infection prevention does, because I'm actually mandated by the governing bodies. So the CDC's division, NHSN, the Joint Commission, it's a regulatory requirement to have an infection preventionist in the hospital, because my main purpose of that hospital, the part that you may not see and know, and the part that I really had to learn in assimilating to this position, was I need to do surveillance in the medical record for infections. If they are healthcare associated infections, I need to report them. So NHSN has roughly a 450-page book that comes out every year with updates, and that is my playbook. So we use the EPIC system. They flag anything that is taken as far as a microorganism, a specimen. So any sputum, urine, blood culture, anything from surgery, any swab. We do nasal swabs for MRSA. They come on my radar. I receive those results and I have to evaluate every one of those results if they are positive. And the sputums can be negative. It just triggers for another type of infection. And I need to see if it meets the criteria for NHSN's infection. And then at the end of the month, I need to report the infections, which a lot of states only have the certain indicators that are mandated to report. I'm in the state of Pennsylvania, so we report everything. So if somebody comes in and is in the hospital for more than 3 days and their wife was sick and say came to visit them and they ended up testing positive for the flu or rhinovirus, we test that patient and they're positive for it. Since they were in our hospital greater than the 2 days, the day of admission and the day after, I have to look and write them up for an upper respiratory infection. Even though we know that the wife was probably the one who gave the spouse, it doesn't matter. They were under our care and they now have an upper respiratory infection. So we go ahead and report it. And then Pennsylvania requires Act 52. I send letters to the patient saying, while you were under our care, an infection was called and reported to the National Health Safety Network. So a lot of my day is spent doing computer work and doing surveillance and getting things into NHSN. Surgical site infections are a big one that they monitor, not only just the colo procedures and the hysterectomy procedures, but we'll send them in for amputation, surgical site infections, or if they had thyroid surgery, many types. They have the list of the ones that they monitor. So aside from the paperwork, and that's the part that I think infection prevention that a lot of people don't know about, we do rounding and a lot of collaboration, and we do water management. So I'll go through and do water cultures throughout the hospital looking for Legionella. And we have a burn tub, we have a burn unit. So we'll test the water for Pseudomonas because, as we know, water quality is really important, and you can't use poor quality water on a patient because you can give them an infection from normal pathogens that are just in water. So we do a lot with construction as well. I go, and if there's a construction going on, we have to make sure that we're not going to release anything in the air as far as aspergillus from drywall, and making sure that everything is sealed off, that the patients don't get any construction dust that can harbor microorganisms and cause problems and infections. So we have negative air machines and air scrubbers. We're sealed off. We make sure that it can't get in the vents. And so I'm in charge of the ICRA paperwork and going and making sure construction is following our protocol. So
in an old hospital, that's probably just like an ongoing thing, right? Where you've got
something
being worked on.
And emergencies. So if a pipe breaks, if somebody flushes wipes down the pipe and the plumbers need to come in and start snaking, but sometimes they split the line and that we need to then seal off the wall and open the wall. That's part of the emergencies that happen. You know, We've had things that have happened in the OR where we've had to block half the ORs and, schedule things around because of emergencies that have happened from, water leaks or sealing or just general issues with not having the correct temperature and humidity in the ORs, or unable to get the positive pressure to maintain the temperature, the humidity in order for a procedure to go on. So there's a lot of rounding that goes on with this environment of care rounding, where we go through an area and we look for anything that we would consider unsafe for a patient. Do we have, a glucometer? Is the glucometer not wiped properly? Is there blood on it? So we need to make sure that there's nothing on the glucometer, not even any of the controls. We want to make sure that no one is using a stethoscope that is a single patient stethoscope going around on multiple patients because we review the manufacturer's instructions for use on everything. And if it says that it's a single patient item or a single use item, I know in the dental world, sometimes we're like, we'll throw that in some glutaldehyde, or we'll go ahead and put some cavi wipe on that. That's good to go.
In
No,
the
that's
hospital.
against but that's against the manufacturer's instructions for use, even for dental. So it has us then to go ahead and go, hey, maybe we need to reevaluate ourselves. I always say that I have my two hats on, that I can understand where you're coming from. And now I'm thinking, I don't think anybody would have me in a dental office for 10 minutes because I would tell them, that's not how we do this. Manufacturer said that we need to go ahead and put that little cap back on after we take the
You know too much, Lisa.
That's it. That's where I go. I said I have to really go with someone who likes me, because no one else is going to tolerate me.
I'm glad you're so sweet. You probably get away with a lot. Don't shoot the messenger.
That's what I'm like.
You must have a team.
Paid. My line is, I'm paid to be paranoid. Yeah. And if the thought comes in my head, unfortunately, I have to say it. So now we just have to make sure we're keeping the patients safe. And they look at me and go, yeah.
Yeah, exactly. Well, that's good. And you're there to help. It's not like you're there to just blow up their world and walk away. Right?
Exactly.
Yeah, you're there to make improvements.
So there's a lot of times they will pull us in for collaboration because they don't know what to do or know how to interpret the instructions for use. Mm-hmm. So there's times that, my 7th floor is my cancer floor where we do the bone marrow transplant, and they will always call us up and ask us, hey, what do I do with this situation? Whether it's about gloves, whether it's about CHG bathing, or a patient with graft versus host. How can we take care of this patient that we're not going to cause an infection, but still have something acceptable for them, because it's sometimes a little unconventional.
Yeah, exactly. So do you have a team?
I'm pleased to announce, let's say, my manager was promoted to network director. So she did excellent work, and I'm very happy for her. Sad for me. And that happened back in November. So we just, through the hiring process, remember I said incremental progress, I was able to have somebody start at the very end of June. So it was quite a while that I was by myself. So I do have a very experienced IP that is now helping me. And she was with the other organization here, hospital system, and she brings a lot of knowledge and a lot of initiatives. And so we're still learning from each other on what can we do and what our program was like compared to what she was doing, and how to make improvements for patient safety and what can we do. So it's just the two of us. Maybe someday we'll get somebody else to come in, because it's a lot, especially we have the most critical care beds. So we have a lot of microorganism specimens that we do process in a lot of surgeries.
Okay. So I suppose some weeks are busier than others. Obviously, there's you're probably.
They are, and
either different.
A lot of meetings. So we are required to report out our infections. So we have certain committees that we need to go and report what the hospital infections are. So it always goes by quarters, but we're normally a month behind in data. So I just had put in July all of my June data. So now we're working on July data in August. So that means I finished Q2. So in August then starts my Q2 monthly report out, let's say, of where we are with our stance of infections for the committees. So it's a lot of now PowerPoints and meeting presentations, and you would be surprised at the things that the quality department looks at on how we can make improvements. So it can be some months more meeting heavy than others. They're not the ones you can multitask during, with teams on in the background and, answering emails.
Yeah, no kidding. So do you do rounding every day then, or is that sort of when you
We try to do every day, but we do have organized rounding at least weekly for the different departments. Physical environment rounding used to be known as environment of care. We are required to visit the certain units twice a year. My hospital, like I said, it's the cancer hospital in essence. We're mom baby, NICU, complicated gynae oncology patients as well. But we have all the cancer centers under my hospital. So we go to all of our offsite cancer centers and we do rounding there as well. So they're part of our license. We go and hold them to the same standard that we do any of the hospital-based cancer centers. So it's multiple times a week that we do go out off sites. And then plus there's always training and education and anything we can do for quality improvement. And we're trying to standardize things network wide. So we all get together.
Is that unusual then for an infection prevention practitioner or infection preventionist to go to multiple sites? Is that
depending on your hospital and your hospital license? So some of my sister hospitals, they don't have many under their license and they don't do the offsite rounding. Some of us have that. So I hit the Cancer Institute. Some of the clinics are under another hospital's license. And so they will go and send a representative, a committee out to go and have eyes on that, because Joint Commission now does rounding at all of our offsite facilities. So we have to make sure that we've had eyes on them at least once a year, that we have to show evidence that we did do the rounding.
Yeah. Interesting. So if I'm a hygienist and I'm thinking, I want to explore infection prevention tomorrow, what 3 or 4 steps would you say is, what should I do?
So infection prevention is one of those weird little niches in the hospital that you don't know that's there, that within my hospital that's in the quality department. So I would probably say the best way to go and get some experience in doing and seeing what they do is to volunteer. So contact the local hospital, but see if, being that you are a hygienist, make sure the hospital that you want to volunteer with does have infection preventionists that are not nurses. Some of them, if the smaller sites, rural sites, combine employee health and infection prevention, and nursing is required because you have to do the employee vaccinations and things of that nature. Right. So you want to make sure that wherever you're going to go and volunteer, you may enjoy volunteering regardless if you think this may not be a path that you're looking to go to. But if you want experience with the infection prevention, thinking, hey, I'm going to make some connections, I'm going to see if I like it, I'm going to find what the other positions in quality may have to offer, make sure that you can be a non-RN position for infection prevention. But I would go volunteer, because we're always looking for help coming in with a lot of the hand hygiene audits. Sometimes you think infection prevention only does hand hygiene. That's a big misconception. That what do? You talk about hand hygiene, wash your hands. Everyone knows to do that. That is definitely a big part of it. And that's the number one way, as we all know, to prevent healthcare infections. However, we need to do for leapfrog grading a certain number of hand hygiene audits per month. And especially during the time when they are coming through and validating all of our information, I get lots of volunteers come through, because some units have to do 200 manual hand hygiene audits if they're not badged with the electronic hygiene system. They have to do the manual audits, and they have to do some regardless of, even if they do have that electronic monitoring. It's a great way to come in and see, envelopes that do need stuffed and letters that do need to go out that I do need to send, things of that nature. It's always wonderful when we did have somebody that understands a bit of what we're doing, why we're doing it, to come through and help. So volunteering can give you a glimpse of everything that's going on. And depending on what you're doing, you may go on rounds with them and get to experience a little bit more.
You're building your network that way. And if you do want to jump in, you know someone and they know your face and know your name because you did good work for them on that.
Exactly.
Yeah. Awesome. Okay. What else should I do? Volunteer. What else?
Volunteer is good, and find out about the rule. A lot of times within our professional organization and things, to get a certification or to get experience with it, you need to be a professional infection preventionist. And some of the classes too are very costly. So in order to attend one of the, introduction to infection prevention classes that they have, you need to actually be a professional infection preventionist. So that is hard. I do know that they do have some dental specific information, which is always good to look at. So you can start within your own office doing some of the dental infection control, understanding the instructions for use, and trying to experience it with a little bit of infection prevention that way to, even though you have a good foundation and a base as a hygienist. But I say when I put on my infection prevention hat, then that's when you're like, oh, we need to go ahead and maybe not do it that way. Yeah. So it's a little bit more difficult, let's say, to get into because of there's not much availability, at least here in the States, as far as exposure to it. There are some people in the hospital when I do new hire orientation, I'm like, I'm with the infection prevention department. Has anybody heard of infection prevention? And there's like 2 people out of 50 that raised their hand that has ever heard or worked with it, because a lot of times you don't want to know us, but when you do, there is always a reason behind it, and TB is one, but the best is the bed bugs. That's when they really come and look for you.
Oh my gosh. Wow. In Canada, we have the CSA standards, the Canadian standards. And before we open a private practice, they direct us to infection control in a dental setting. And we have to do, I believe it's 11 hours online and complete that before. That's kind of like one of the first things you do. And it's really just to revisit everything you learned maybe years and years ago about infection prevention. It's a great reminder. And a lot of that is, really by the book, and you realize, oh, maybe I have a lot of bad habits that I learned in the dental office. Right?
Exactly. No, and that's fantastic. A lot of times too, when I go through and I talk with people, and I know this from the dental world, legacy. You come in and somebody said, oh, this is the new product. Oh, this is how you clean it. And you're like, okay. And that was essentially your competency. Yeah. Nobody questioned it. Nobody looked at the IFUs. Nobody even thought anything of it. Oh, no, we just go ahead and wipe it. Well, the person that maybe read it and started that up was 4 people ago, and something fell off each time. And when you go and something breaks and they come in and they're like, you don't do it like that. And you're like, oh, I have no idea what you mean. That's the way I was
I've done that for 10 years.
Yeah. It took this long to break. We're good.
Well, thank God you never killed anybody.
Isn't that the truth, right? That we know of.
Oh my gosh. Okay. Very good. Okay. And then extra education, any other comments on extra education that you've done sort of along the way or before you?
So when I was first onboarded, I worked for about, I would say 6 months. And then I did go to the APIC Introduction to Infection Prevention, where they went through everything and really exposed me to some of the other sides that you may not get in a hospital, because a lot of what you learn is a day-to-day experience. Somebody calling and saying, we had a TB exposure in the emergency department. We had, shingles exposure, patient wasn't an airborne and they disseminated. So there's a lot of outbreaks, exposures, things of that nature that are all hands-on, but they help give you the foundation of chain of command to go and report things to, and what is the best way to start an investigation and going back. I then did a lot of the online courses to become board certified. And that was a job requirement that was there. You need to be an infection preventionist at least for 2 years before sitting for boards. And I was fortunate enough to go ahead and be able to, on my first try, become board certified. It's funny, everybody I think would appreciate this. Everybody's biggest, when you take those pre-tests, biggest hang up is sterilization. So that's what I laugh and I'm thinking, okay, well, all of us hygienists got this because it were the questions that they were saying and answering. I'm trying to tell my coworkers, we called it the rule of 25s. Okay, so it's 27 now, at 270 or 27 PSI, but we called it the rule of 25s. So you think along that line, I said, that's how we got it through boards, 30 years ago. But a thing that had helped me that, let's say, maybe is not infection prevention related, that has really made a difference, and especially with education and educating my nursing floor, is I first was introduced to this forum because I was looking for something more with oncology. I felt, as I'm sure many of you, when you're in an office and a patient comes in and they're saying, well, I'm on a cancer pill, what does that even mean? Or I'm starting to have problems or mucositis or other things, side effects from chemotherapy that the patients come in. And as we know, some patients they're on chemotherapy for the rest of their life. It is just the way it's going to be. It's not curative. It's just keeping them going. So it's not that they're not going to get some dental treatment. They're just going to come in with it. So the oncology certificate program has made such a difference for me in my working every day, because I collaborate with the floor, with the bone marrow transplant patients, with graft versus host disease, with needing body of washing the patients with the chlorhexidine to prevent central line infections. But what can we give them? I'm trying to get them away from that magic mouth rinse and go to the bland rinse, because my oncologists and providers, they're going by legacy scripts. We give some chlorhexidine, we give some magic mouth rinse. So I'm taking a lot of what I have from that, oncology certificate program to educate everybody there, the providers, everyone from the APPs to the doctors to my speech and language, because they're not understanding what's happening to the patient, and they don't realize the resources that we can go and collect and do that are, if you want to say, over the counter, because if we wanted a new product, we've got to get that product care committee.
Right.
And I'm not getting that mouth rinse in there anytime soon.
7 years down the road. It's great
exactly.
that you can incorporate that knowledge into what you're doing.
It's helped tremendously. And I'm in the middle, and I must say, I was doing well and going to start with the oral systemic educator. I was going to go and get that done very timely, and my boss had to go and get promoted to director. And then there was a lot of, let's say, brain fatigue coming home from going through all of this for 7 months myself. I'm like, I'm not retaining anything. So now
doing
that
the Lisa show, it's just me. I'm here all night, every day for 7 months.
And on the weekends, trying to get this data in. So now I'm like, okay, kids go back to college tomorrow. Things are changing. I'm determined to get this finished, because I'm looking to bring and collaborate more of the, oral health integration, and trying to promote that on the other floors, because that's a part that I can work with education and do and improve. So that was the extra bit, not with the infection prevention. It's my hygiene background that's promoting these changes and making a difference, because it's what isn't available in the hospital, because nobody has that knowledge.
Because of that separation.
Yes.
And the body still a lot separate. Getting there, one person.
Incremental progress.
One OSE, oral systemic educator at a time. So I think I could probably guess this, but tell me what the most rewarding part of your job is.
The most rewarding part is really just trying to make it better today than it was yesterday. Trying to at least help one patient or solve one problem, or know that I could have prevented one infection from happening, and then sometimes I will admit that I've had to be the bad guy. But when I get water cultures coming back saying the water isn't what I need it to be, and I have to close those burn tubs and send those difficult emails and critical conversations, that our patients now are going to have to go to the OR for treatment instead of, having dressing changes in the burn tub room, that, yes, it may have been inconvenient, but the patient safety was top priority. And I'm just fortunate because I must say, my hospital, I've had nothing but support with some of these critical conversations that have been uncomfortable, that could, make it inconvenient for everybody. I've had the full support, and they've been completely understanding, going, nope, it is in the patient's best interest. So making things better.
Yeah, you're maybe the bearer of bad news, but it's not bad news.
No,
it's improvement, right? So at the end of the day,
absolutely.
it just makes the environment better outcomes for the patients. But I can see when somebody has to do, we're all sort of averse to new things at some point in our lives, especially when we're really busy and working hard. And then it's like, okay, now we got to revamp something. It's difficult for people in general, but the work that you're doing is really important. So you just keep getting out there and doing your thing. So what have we not asked you that you feel like we should know about infection preventionist role? Is there anything we haven't discussed? I don't see any chat questions, so we must be doing a pretty good job.
I hope so.
Yeah.
I think the knowledge, considering the audience that we have, all being hygienists, I think the knowledge that we have as a hygienist with sterilization, really in time management and thinking 3 steps ahead of what we need in preparation, all of that really has just helped me with this. But I think they're transferable skills to anything that you may want to do. There's patient safety in the hospital. And a lot of times, patient safety, there may be a problem with sterilization or coming back and not having the good, why, when we open up this pack in the OR, all the instruments spotted, or they look discolored, or it's the quality of water, or things that we see and know to flag for, that we've helped prevent through using the water and the distilled and not using the acidic products on it. Understanding that and going and realizing that for an OR procedure, what fail safes that we have to make sure the instruments are sterilized, on not using dirty instruments on a patient, are really essential. So that part of infection prevention, having a dental hygiene background and hygienists being able to work in that environment, is something that is another opportunity for them. So, there's a whole department there that does nothing but sterilization. And not that that's how you want to spend your day, but I know when I had a busy, hectic day, I always tell, when it gets busy at work, I always tell Cassie, my manager, I think one of these days you might see me knocking on your door and I'm going to say, I think I need to come and work for you for a while. Because I always found it soothing to take something dirty and make it clean again.
Yeah.
And go through the sterilization. So, infection prevention does get their hand in that and looks at the quality of the products and does that. But, knowing the skills and the knowledge that you have, don't sell yourself short in finding something else that may be rewarding for you, because there's whole departments in the hospital that you can go and excel at.
Exactly. Just if you just kind of think of it that way, that part of what we learn and how we can extrapolate that into something completely different.
Absolutely.
Right? It's completely different. It's for you on your day-to-day basis, right? And it totally fit with where you were at. I know there are some hygienists that really rise to the top, and they're the infection prevention officer in an office. So someone like who really, they, all those kinds of things, really, it satisfies them to have those things, really, the structure there. And that gives them that warm, fuzzy feeling. Those are the people, right? That would do well in your position. So Tana has a question here. Is there any other job titles for infection prevention? Sometimes she's noticed that some jobs have several different titles depending on the organization. So maybe outside of hospital, I'm thinking.
Now, long-term care facilities, some nursing homes, they all have infection control infection prevention. Normally, it's under those two titles. Infection prevention and control, a lot of times, is what the titles are. But that's primarily having one of those. But there are different facilities that do require monitoring and reporting to the government and are a requirement for whatever regulatory certification that they may be under to have a person there doing surveillance.
I'm curious if the infection prevention world and amongst your colleagues, are you guys concerned at all with the new vaccine guidelines?
Oh, yes. Yes. Oh, that is definitely something that is always a topic. And there's several posts that come out that we recommend. The old standards, and we just want everybody vaccinated. There was a reason why the vaccines were invented, and polio and measles and things, smallpox, all things like that, that there was a need for them how many years ago. So now, just because it's not something in the forefront doesn't mean the need for them has gone anywhere. So they are supporting the old vaccine schedule. And, everybody's saying we just really need everybody to be vaccinated and get that herd immunity back. And then
there's a reason why we're vaccinated against these things that no one's heard of, is because we want them back. But for you, I mean, the infection side of things, right? That's one way to be to not spread infection. So I'm curious how that's gonna.
And we've noticed in the hospital. Yeah, we've noticed in the hospital, and it's unfortunate, employee health always reports out our compliance with flu. And, there was at a time that the institution said if you did not get your flu vaccine, they wanted to have, a 90-something% rate that if you could get vaccinated, and unless you had that medical reason why you could not because of an allergy or something substantial, they wanted you vaccinated. If not, and you refused, you had to wear a mask during respiratory season. And there were times recently, prior to COVID, that if they were not vaccinated against flu, that you would see people walking around the hospital with a mask, especially if they were patient forward facing. Then, with the different vaccines and that, our flu compliance has definitely dropped off to not optimal levels, as well as the COVID. So they're trying to encourage everybody again to definitely, consider the vaccines, but they're not requiring the masking as they had done previously.
Yeah. Oh boy. On that note, are there any last questions that anyone had on their minds for Lisa tonight? If you did want to get in touch with her, she's listed as Meet the Team on our website, and her information is there. You can reach out to her if you like, if you had some questions that you'd like to ask her. I think it's Lisa at healthcarehygienist.org. Is that correct? I'll just type this.
Yes.
Healthcarehygienist.org. Healthcarehygienist.org. There we go. Great. Thank you very much, everyone, for coming out, and we will we'll have another live discussion coming up, hopefully sooner than later, and I'll be happy to see you guys again. Thank you for coming. Thanks so much, Lisa.
Thank you, Colette. I appreciate the opportunity.
Yeah, it was great.
Thanks, everybody.